Pain and redness in or around the eye of recent onset is a commonly presenting ophthalmic complaint in both adults and children. On most occasions, the diagnosis of a painful red eye, aided by a careful history and good examination, is obvious. However, this is not always so, and mistakes can be made. The causes of red eye are multiple, but here are a few hints about the examination. Firstly, measure the corrected and pinhole visual acuity. Simple causes of red eye, such as conjunctivitis, will not usually interfere with vision. Markedly depressed vision suggests serious disease, such as severe uveitis or acute glaucoma. Then proceed to examine both eyes in a systematic way. This examination will include the skin around the eye, the lids, conjunctiva, both tarsal and bulbar, and the cornea, followed by the anterior chamber, the iris, and the lens. The skin around the lids, best examined in daylight, of the affected eye may produce some diagnostic clues. There may be early signs of a rash, for example in herpes zoster ophthalmicus, where the rash follows the configuration of the trigeminal nerve. A headache, which can be severe, is confined to the same side as the rash. In orbital cellulitis, the skin may be inflamed and associated with proptosis, whereas in preseptal cellulitis, which causes lid swelling and redness of the eye, but does not, unlike orbital cellulitis, interfere with eye movement or threaten vision. Preauricular lymph gland enlargement may indicate a viral conjunctivitis. Examine the lids with torch and magnification. The slit lamp is best if it's available. Evert the upper lid to examine the upper tarsal conjunctiva. This may reveal a subtarsal foreign body or the presence of follicles as in trachoma, or papillae found in vernal catarrh. In the lower conjunctiva and fornix, note the presence of any discharge. For example, glue-like in infective conjunctivitis and stringy in vernal catarrh. In the bulbar and limbal conjunctiva, redness is usually brick red and generalized, as in bacterial conjunctivitis, but it may be localized to the limbal conjunctiva or have a bluish tinge suggestive of iritis. In vernal conjunctivitis, papillary lumps may also be found at the limpers. Examine the cornea and anterior chamber, initially with magnification and white light, the slit lamp is best, and then with fluorescein staining and blue light to identify damage to the corneal epithelium. This will help to identify foreign bodies and other forms of trauma, both mild and severe, ulceration, infective and non-infective, and other non-specific corneal changes, for example, punctate epithelial keratitis. Opacities both old, for example from healed hepatic ulcers, and new, from recent adenoviral infections, may be present. Edema, if generalized throughout the cornea and associated with a hazy view of the iris and lens, suggests elevated intraocular pressure due to angle closure glaucoma. This is confirmed by measuring the pressure. On the back of the cornea, collections of white cells, called chorotic precipitates, might be found and hypopyon may be present. This might be caused by sterile uveitis, but it might also indicate intraocular infection, for example after recent cataract surgery, and this demands immediate treatment. Flare and floating cells in the anterior chamber is always present with inflammation. And inflammation from either a current episode or from previous attacks may cause adhesions between the iris and the lens to form, posterior synechia. Blood in the anterior chamber, hyphema, may be found following, for example, trauma. Sometimes the cause of a red eye might be much more unusual, such as in cases of scleritis. In summary, systematic history-taking and examination is necessary to unravel the various causes of painful red eye. Causative conditions may be either quite trivial or may be serious and sight-threatening. Good luck.